Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, welcome to Clinical Clips. My name is Dr. Stephen Liu from Georgetown University in Washington, D.C. On this, the final day of ASCO 2024, we want to highlight some of the clinically relevant clips from ASCO focused on the EGFR mutant subset of non-small cell lung cancer. This subset, accounting for about 20% of lung cancer, is one where we know we have effective targeted therapies. What we saw at ASCO this year were some refinements to treatment, some new drugs, new approaches, and some immediately practice-changing studies. The first to talk about really is the plenary abstract of the LAURA trial, a randomized phase 3 trial that took patients with EGFR mutant non-small cell lung cancer that had unresectable stage 3 lung cancer. Those patients were treated with standard of care chemoradiation. And after chemoradiation, they were randomized to osimertinib, a third-generation EGFR TKI, or placebo. Unlike ADAURA, which is after surgery, patients receive 3 years of osimertinib after surgery. Here in LAURA, after chemoradiation, patients receive osimertinib indefinitely. What we saw was a profound improvement in progression-free survival, with a median progression-free survival of 39.1 months, compared to only 5.6 with standard chemoradiation. Hazard ratio 0.16, incredible benefit, very wide separation of those curves. The rate of being progression-free at 1 year was 74% with osimertinib, only 22% with chemoradiation alone. Overall survival, the curves were trending, but this is very immature and is not yet significant. Also note, pretty high rate of crossover in this study, which is good in terms of study design and certainly good for patients that enrolled. May complicate our analysis of survival, but really this does look at early versus late delivery, and the PFS benefit here was dramatic. One of the concerns we had was, would giving osimertinib right after radiation lead to higher rates of clinically relevant pneumonitis? Unfortunately, the safety signals in this study were quite reassuring. What we saw was radiation pneumonitis was more common with the osimertinib, but only 48% versus 38% in the control arm. Not so different, and most of these were low grade. This is a well-tolerated agent, and while true, it is given here a long time, it is significantly improving progression-free survival. Again, that hazard ratio is 0.16. When we think of what stands out about this study, one question we have is, do we need to give treatment this long? The second question is, why was the control arm so poor? The study seemed to have done very well, but we don't know if everyone had a PET scan, a proper brain MRI, if everyone was truly stage 3, or did some patients with subclinical stage 4 lung cancer enroll onto a study like this. When we look at the control arm, the median progression-free survival of 5.6 months is quite poor. And while our intent is cure with chemoradiation in a stage 3 setting, here we can see clearly it's not our expectation with chemoradiation alone. And delivering osimertinib afterwards, profoundly improved outcomes after this was presented with a simultaneous publication in the New England Journal of Medicine. This changed practice. Now we consider this standard of care right now. Hopefully the FDA approval will follow shortly afterwards. A question we have, though, is, are we overtreating some people? Does everyone need osimertinib? And even more importantly, does everyone need osimertinib forever? Now, this ties into another oral abstract that we saw, an update from the ADAURA trial that's presented by Dr. Tom John, and this looked at a new blood-based assay to detect minimal residual disease. This was a feature of the ADAURA trial. This is adjuvant osimertinib for 3 years after resection of an EGFR mutant non-small cell lung cancer. What they saw was minimal residual disease using this tumor-informed assay was not really seen in stage 1B. It was seen in stage 2 and higher. It did seem like there were more cases of detectable minimal residual disease if we did not give chemotherapy. And one wonders if this is support that we should be giving more chemotherapy for resectable stage 2 or 3 non-small cell lung cancer. We did see that detecting MRD at baseline was associated with a poor prognosis. And what I thought was particularly interesting is those that had MRD at baseline and cleared with osimertinib, sometimes that MRD re-emerged after a 3-year course was completed. Could this be used to monitor more frequently? Could this be used to identify patients who need more therapy, or tell us when it's safe to stop treatment? If we follow this study along, this blood-based MRD assay was able to identify recurrence a median lead time of 4.7 months, which is valuable to us, knowing that we can detect recurrence before it's clinically significant, maybe opening the door to personalizing or tailoring that duration of treatment. Some of the other studies we saw were in the stage 4 setting, where our frontline standard of care is in flux. Since 2018, Flora, osimertinib alone, has been our standard of care. But in the past year, we've seen 2 other phase 3 trials improve on the PFS of osimertinib alone. One, the combination of osimertinib with chemotherapy, the FLAURA2 regimen. The other, the combination of lazertinib, a similar third-generation EGFR TKI, and amivantamab, a bispecific antibody targeting MET and EGFR. That's the Mariposa regimen. There was an oral abstract update from Mariposa that looked at amivantamab plus lazertinib compared to osimertinib in patients with EGFR mutant lung cancer that had high-risk features. And we're looking specifically at what we know to be high-risk, poor prognosis: brain metastases at baseline, liver metastases at baseline, the presence of a TP53 co-mutation, the presence of detectable ctDNA at baseline, and the lack of clearance of that ctDNA. And the question here, in those high-risk subgroups, is amivantamab lazertinib better than osimertinib? Is there a particular high-risk group where this drug is much better than osimertinib? And good or bad, we saw amivantamab and lazertinib was effective across the board. In all of these high-risk groups, the combination of ami-laser was superior to osimertinib. I don't think that it whittles down a subgroup that in particular needs this regimen, rather providing support for this regimen on a broad basis. And so amivantamab lazertinib effective across all of these high-risk groups, which is reassuring to see, but we need to continue to refine the different biomarkers that we have. We're also trying to refine delivery. And what I thought was a particularly surprising, in a good way, abstract was Dr. Natasha Leal presenting the Paloma-3 trial. This, a randomized phase 3 trial looking at amivantamab and lazertinib, but the amivantamab was given subcutaneously or intravenously. The primary endpoint here was one of pharmacokinetics, looking at the mean geometric ratio, looking at are they equivalent from a pharmacokinetic standpoint, and they were. The subcutaneous, which, by the way, can be given every 2 weeks, 3 weeks, or 4 weeks, was really equivalent to the IV in that standpoint. The progression-free survival is very similar. Interestingly, the overall survival was actually a bit better with subcutaneous, which really had a lot of us talking, wondering if it has to do with engagement of the lymphatic syndrome or some sort of immunomodulatory effect. But that survival effect will need to be confirmed. That was an exploratory result, but it did seem to be a little bit better than the IV. And importantly, giving subcutaneous decreased the risk of infusion reactions. The infusion reactions that were seen were very mild. There were fewer venous thromboembolic events, shorter time, which can benefit patients from a quality of life standpoint, a very patient-centric approach. Really, after that presentation, as soon as it's available, I see no need to give intravenous. Really, subcutaneous should become the standard of care. Another study of amivantamab lazertinib was presented by Dr. Helena Yu, looking at this combination in patients with leptomeningeal carcinomatosis, a very deadly, very difficult, challenging area of spread in this setting. Patients with acquired central nervous system metastases, leptomeningeal disease, were given amivantamab lazertinib. Based on Mariposa 2, we do suspect there is some cranial activity with amivantamab. And so what we saw here is in patients with progressive brain metastases, the combination of amivantamab lazertinib had a response rate of 40%. In patients with leptomeningeal carcinomatosis, where I think response rate is probably not the most reliable outcome, patients remained on treatment for 8.3 months, quite a long time. This certainly a step in the right direction, also, though, an area that needs continued study and really new options. There was another abstract presented that looked at amivantamab in a different setting, though, and this was really looking at it in patients with a different type of EGFR mutation. Up to now, we've been talking about deletion 19 and exon 21 LA58R, but we saw a presentation of amivantamab lazertinib from an arm in the Chrysalis 2 trial presented by Dr. Byung Cho, looking at atypical EGFR mutations. Now, in that subset, afatinib is the approved drug, but amivantamab was studied in this setting, and really the largest study prospectively in this group. This looked at atypical mutations like G719, L861Q, S768I. And what we saw here, the safety profile was really the same, but the response rate, 52%. In the frontline setting, the response rate, 57%. And median progression-free survival here, quite long, 19.5 months. 78% of those responses still ongoing at 6 months. I'll be eager to see how this matures, if this number gets even better, but this is a very appealing and interesting option for atypical EGFR mutations. And we have to predict down the line what we think of amivantamab here, amivantamab chemo, like a Papillon regimen, what we think about sequential use, a lot of possibilities here, but clear activity in that setting. The last abstract I wanted to mention was a slightly different approach. These are patients with EGFR mutant lung cancer who had already progressed after TKIs, where our standard might be chemotherapy. And in this setting, patients in the Harmony A study were randomized to receive chemotherapy, which I would consider standard, or chemotherapy plus ivonescimab, which is a bispecific antibody that binds to PD-1 and VEGF. And what we saw here was the addition of ivonescimab to chemotherapy pretty significantly improved progression-free survival, with a hazard ratio here of 0.46 and benefit across really all of the major subsets. Survival sort of immature at this point, but really encouraging results here. And one wonders if targeting PD-L1 and targeting VEGF at the same time through a bispecific might be better than targeting them separately with different monoclonal antibodies. Could this be how we get better long-term immune-mediated responses in this group, which is typically known for lack of immune responses? Time will tell what the tail of that curve looks like. But I think a lot of very impressive and encouraging activity, a lot of updates. This is just in EGFR. We saw a lot more in lung cancer overall. So exciting times, progress clearly moving forward. With that, we'll close the clinical clips. Thanks for joining us.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.